Hi, welcome to the Pain and Alterations in Comfort lecture. Okay, we're going to begin by discussing some definitions of what pain is. According to your book, pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. And then McAfee, who is really one of the nurse experts on pain, has defined it as whatever the person experiencing it says it is, existing whenever the experiencing person says it does. That's a pretty popular definition in nursing theory to this day. And the American Pain Society encourages nurses to view pain as the fifth vital sign, and so to assess it as frequent. Okay, and now we'll just discuss what pain isn't. Pain really is not what the nurse or doctor determines a patient is feeling despite a client's report. It's also not relying primarily on changes in vital signs or deciding whether a person looks like they're not in pain or knowing how much a procedure or disease should hurt, whether it's based on other clients or based on personal experience. It's not assuming that a sleeping or laughing client doesn't have pain, or rather it doesn't mean that assuming that clients will tell you necessarily when they're having pain. And I know all of you in your experiences, even as student nurses, have probably been in situations where you've worked with clients who have been requesting pain medication or maybe are reporting pain. And you'll hear comments such as, well, they don't look like they're in pain. They said they're in pain. I came back later, they're watching TV and laughing. So try to consider these statements when assessing pain. Okay, what pain assessment is. Pain assessment is asking and believing the patient. It is really the nurse's primary role in pain management is being the advocate for your client by believing the reports of pain, because your client is really the only authority regarding the pain that they are experiencing. It is a unique experience for them and one that we just have to have some trust in our clients and believe the report. Okay, the gate control theory of pain was developed by Melzick and Wall, and as I wrote here, it's the first theory to take a holistic view of pain and pain management. It was actually a pretty simple concept of a railroad switching station where it opens to the favored area over the unfavored area. So for instance, a gate control theory is based upon the fact that nerve fibers transmit pain impulses from the periphery or from the body to the dorsal horn of the spinal cord, and they normally travel through something called substantia gelatinosa, and that's where this gating mechanism occurs. So if the gate is open, then the pain impulse travels to the brain where it's perceived as pain. But if it's closed, then the pain doesn't get perceived. An example of something that might close those gates are endorphins. They're thought to close the gates so they decrease the actual pain transmission. That's why a lot of non-invasive pain management techniques such as massage or relaxation or music therapy are thought to be effective because they release endorphins that can close those gates. There are many factors that influence pain and pain perception, and we're going to go through all 6 of these: physical, psychosocial, social, spiritual, cultural, and then briefly look at age, gender, and personality types. Physical factors influence pain perception because basically every person has a different way of perceiving pain. And when you ask your client, can you describe your pain to me, you get a whole variety of descriptors. Everybody has a little different pain threshold, and pain tolerance can vary even within one patient from one experience to the next or from patient to patient. So try not to superimpose your experiences again on the patient, whether it's your personal experiences or your experience with a patient or family member who's undergone a certain situation, because physically everybody is different with those. By the way, women are at greater risk of undertreatment than men. And research is going on now, actually, to look at different treatment modalities between men and women and how they may actually respond differently to common treatment modalities. Some other physical factors that influence pain are the type and severity of the pain. For instance, is it an acute or chronic type of pain? And we're going to talk more about specific defining characteristics of those in just a bit. Is there a presence of other symptoms such as nausea, anxiety, etc.? Or perhaps there's some adverse effects of the treatment of pain, like post-anesthesia symptoms. Here's a quote that I found. It says, "We all have experienced a pain that we would call excruciating. It may be, say, a stubbed toe for some, or wisdom teeth extraction for others. In any case, we've all experienced the quote-unquote worst pain of our lives." However, even in this statement is the implicit idea that we no longer experience this worst pain. The pain subsides, we eventually experience relief. And that is kind of a good way to describe acute pain. Now, chronic pain is very different from acute pain. Although it may start with an injury that causes pain, sometimes it doesn't. And unlike acute pain, chronic pain persists. In chronic pain, the pain signals relentlessly fire in the nervous system, perhaps continuing for years, even perhaps a lifetime. This is the sort of pain that Emily Dickinson had in mind when she wrote this verse that says, "Pain has an element of blank. It cannot recollect when it began, or if there was a time when it was not." So when you have a client who's experiencing chronic pain, consider this statement. I know I do, and it's true. It's hard for them to recollect when they actually were free of pain. Okay, there are psychological factors that influence pain. For instance, a patient may be experiencing anger. Perhaps they're angry about the delay in diagnosis or a treatment failure. Pain can be influenced by the fear of the disease, fear of pain or death, disfigurement, feeling of helplessness, whether it's helplessness to get pain relieved, or maybe a family member feeling helpless to fix the problem. A person or client could experience fear of being a burden to society, burden to relatives. I know sometimes patients, it'll come on the next slide, but they could actually develop a fear of being a burden to a healthcare provider, their physician, or the interdisciplinary team. Patients may experience worries, whether they're financial or about the future, or concerns that can affect their pain experience. They may appear hostile or desperate in nature. Social factors that could influence the pain experience: worrying about a family or finances, loss of a job, prestige or income, that kind of fall in the area of role function, as would be loss of a social position or loss of role in a family. Clients could experience feelings of isolation and abandonment, and I think especially of those of our patients who are in contact precautions, how they must doubly experience those feelings of isolation. And finally, as I talked about before, fear of bothering healthcare providers, especially the nurses. I've heard patients so many times saying, "I was going to call, but I know you guys are busy." And so just encourage them to call whenever they have pain. Make sure to keep reinforcing that. And when you say you're going to do something, do it. There could also be spiritual factors which influence the pain experience, questions about meaning or purpose in life, about suffering or the meaning in suffering. Some may experience fears about the past wrongs catching up with them, or even questions about God or a higher power. Now, in our role as nurses, sometimes we would feel comfortable intervening in this area or offering support or just listening. Other times you could refer to pastoral services in your agency if there's such a thing, or at least check their chart or ask them if they have a spiritual leader or somebody who could give some kind of guidance in this situation. And of course, there are cultural factors which can influence the pain experience, ranging from the demographic variables such as age, sex, or religion. And then also the cultural background or even race can affect how the person expresses how much pain they're having or their pain medication needs. And also they may have a different view of the meaning of pain. So I guess I would just encourage you when you're working in the community with, no matter where you work in the future, with certain cultures, that you would investigate and find out how you can be an advocate for that set of the population. Okay, next we're going to look at the simple difference between acute and chronic pain. Okay, acute pain is generally caused by an injury, disease, or surgery. The amount of pain usually decreases with healing and is reversible. So patients may interpret the pain as necessary or even expected, and because they know there's a certain duration of the pain, it's many times easier for the patient to deal with this than with chronic pain. Okay, it is estimated that about 250 million Americans have chronic pain. Chronic pain is defined as long-term in nature, usually more than 3 months. Many times it's accompanied by depression. And there's kind of a classification of chronic pain into cancer pain and non-cancer pain. Cancer pain would obviously is the pain as a result of the life-threatening process of cancer. Examples of that might be, say, a tumor invasion, nerve compression, bone metastasis is very painful. And chronic non-cancer pain is actually more common. It affects people over the age of 65 years of age. And it's a type of pain where the pain really serves no biological purpose. It is just something that has to be dealt with for months, years, or even for a lifetime. Some real common examples of that in our elderly population would be, say, rheumatoid arthritis, chronic back injuries, or osteoarthritis. Types of pain can also be divided into 3 categories known as somatic, visceral, and neuropathic pain. Your book does talk about this a little bit, so we'll go into depth just looking at them one slide each. Okay, we'll start with somatic pain. Somatic pain is caused by activation of nociceptors in the cutaneous, deep tissues, and musculoskeletal system. Now, a nociceptor is a sensory receptor that responds to potentially damaging stimuli. It sends nerve signals to the spinal cord and to the brain. And the actual process is called nociception, and it's really what causes the perception of pain. So somatic pain is caused by the activation of these devices, if you will, and the cutaneous, deep tissues, and musculoskeletal system. As far as assessment, you will see a pain with movement, or a client might say, I'm fine if I don't move, if I just lay still. Descriptors patients may use when you ask them if they can describe the pain. They might say it's aching, gnawing, constant, well localized in a certain area, a dull ache or throbbing. Some specific examples post-surgery: bone fractures, bone metastasis, infection, inflammation of soft tissues, muscle spasms, or inflammation. I also have in my notes like a sprained ankle as an example of a somatic type of pain. Okay, so the second type of pain is visceral pain. And visceral pain is caused by an activation of the nociceptors from situations such as infiltration, compression, distension, or stretching of thoracic or abdominal viscera. When you think of abdominal viscera, think organs in your mind. As far as nursing assessment, you may discover patients are experiencing either dull or sharp pain, deep and constant. Could be a vague type of discomfort or difficult to localize or even difficult to describe. As far as descriptors clients may use when you ask them to describe their pain, they may say deep and squeezing, pressure, cramping. It's also associated with nausea, vomiting, diuresis many times because it does involve the organs and the viscera. Some examples I've listed here: bowel obstructions, pleural effusion, pneumonia, menstrual cramps. And I'd also like you to keep in mind the visceral pain can also, and many times, is referred, and that is where there's a sensation of pain located in the area that's distal from or distant from the actual area of injury. And I'm just trying to think, probably the most common type of referred pain is the type of pain associated with myocardial damage, which, as you know, is angina. Angina, sometimes they can feel it in the chest or epigastric area, but many times it's radiating to the jaw, down the left arm, even to the wrists or elbows. I think last semester you probably learned about gallbladder pain, which many times is manifested by scapular pain on the right side of the body. And if you've ever eaten ice cream really fast, you've experienced something called brain freeze. I think everybody's experienced that. That's a perfect example of referred pain. It's referred because the pain is caused by ingestion of very cold substance. And there's vasoconstriction and dilation of the capillaries, and actually the trigeminal and vagus nerves are stimulated, but the pain sensation is felt in the kind of the upper head or the brain area. And then finally, the last example of referred pain I'd like to mention is phantom limb pain. This is a type of pain where clients who have had an extremity removed may continue to experience pain in that extremity even though it's no longer there. And it generally goes away after quite a long time, but it can be very severe and debilitating. The third type of pain I'd like to discuss is neuropathic pain. Neuropathic pain is caused by spontaneous discharges in the central or peripheral nervous system. As far as the assessment, you would probably be assessing a kind of continuous or intermittent tingling type pain, which is also known as paresthesia, hypersensitivity to the skin, nerve compression, or damage. If you would ask a client to describe this type of pain, they would probably describe it as burning, aching, shooting, maybe pain or numbness, tingling could be in there. Examples would included in this would be peripheral neuropathy, many times experienced by diabetic clients. Those experiencing trauma to nerves or nerve endings could be, for instance, a motor vehicle accident patient, or even somebody who has, say, lumbar disease or lumbar disc bulging, where those nerves are compressed and, they'll experience a tingling and numbness down their leg. And herpetic neuralgia is considered a neuropathic type of pain. Herpetic neuralgia is what occurs after a person's had shingles. As you know, shingles is a herpes-type disease, skin rash, and it'll be resolved, but they could experience very severe pain for quite a long time after that. And then finally, trigeminal neuralgia, also known as tic de la Rue, is caused by damage to the trigeminal nerve. It can actually cause very relentless facial pain. And if you ever Google this or want to look it up, you'll see that it's coined actually the suicide disease because it's very difficult to deal with. I've cared for patients in acute care who are they're on trials for different medications, trying to get control of this neuropathic type of pain known as trigeminal neuralgia. Okay, now we're going to take a bit of time to look at pain assessment across the lifespan. Okay, so this is a review from, I'm sure, a couple of semesters now, but when you assess a client's pain, you want to certainly assess the location, duration, quality, and type of the pain. And I know you guys are doing that. I see you doing it routinely in clinical. Factors that relieve or increase the pain, the impact of the pain on their quality of life, and the patient's previous response to treatment, and their preferences. Many times you look at the PRNs, and there'll be a whole page of them, and I'll frequently ask, what works best for you, and what do you prefer? So we are going to be looking at some pain scales. We're going to be looking at the 0 to 10 scale, which you're all very familiar with, a visual analog, FACES, FLACC, and then the newborn and young infant scale. And I think I included those all on your PowerPoint so you can follow along. 0 to 10 scale, you're very familiar with, the worst possible pain to no pain at all. However, the FACES scale on the right side of this screen is appropriate for children maybe starting right around 2 years up to about 7 to 8 years of age. After that, they can usually respond to the numerical rating. So to ask them which face corresponds to how they're feeling. Here's another interesting pain scale that I haven't seen used a lot, but boy, I think in Wisconsin we could really get a lot of use out of this. What is your weather today? Take just a minute and look at this and tell me, how are you feeling today? Are you experiencing any pain? Are you sunny with no pain? Or maybe just some intermittent pain, showers? Or severe pain where you're not really able to participate in the activities, you're snowed in, and most activities are canceled for the day. And that would correlate to a 10 on the pain scale. This pain scale by Mosby is just another variation of the FACES. It's horizontal as opposed to vertical, and it uses different words as opposed to just numbers, which the original FACES pain scale has words. No hurt, hurts a little bit, hurts a little more. Could be nice for people who do not speak English, or again for those about 7 years old and under, maybe like 2 years to 7 or 8. And finally, this FLACC scale is very commonly used in our region. It's used for children under 2 years of age and older than about 2 months. So 2 months to about 2 years. And you'll be assessing 5 things. One is the face, whether there's expression or smile, grimace, or frown, clenched jaw, quivering. Legs, you would assess whether they're normal position or relaxed, uneasy, restless, or tense, or kicking, or drawn up. I think of a child who's experiencing colic, say a 6-month-old who's pulling their legs up in severe pain. As far as activity, are they lying quietly, squirming, arched, or rigid? Is there crying, either absent, no cry, moans or whispers, or steady cry? And finally, consolability, whether they're content and relaxed, or number 1 would be they're able to be reassured by picking them up, hugging them, talking to them. And number 2 would be difficult to console or even impossible to console. Now, as far as a FLACC scale, I don't want you to memorize what each number stands for, but I'd like you to know who it's best used for, kind of the 5 categories, and how they all work together to interpret the patient's experience of pain. Okay, and this is a newborn young infant pain scale. As you can see, it's a little less discriminatory. It's either 0, 5, or 10. And you can see that just defining characteristics under each number. Some of them are similar to the FLACC scale, for instance, difficult to settle, grimacing, but they will use this on the newborns in order to determine the amount of pain they are most likely experiencing. And finally, you'll want to, of course, document what you have assessed and done. You want to document the client's report of pain, the patient's goal for pain relief on a scale of 1 to 10. That should be clearly identified wherever the agency requires it to be. Plan for pain management, interventions by the nurse, and the client's responses to those interventions. I know at Aspirus, patient must be reassessed within 2 hours or less of interventions. Now the following slides are going to talk about nursing interventions for a patient in pain. Okay, so now we're going to be looking at nursing interventions for clients in pain. We're going to focus on medications, medication delivery systems, and at the end of this handout there are just a few slides on non-pharmacological approaches. We won't really be discussing them in depth, but it's something for you to consider. Okay, so non-opioid analgesics, the primary one I'd like to talk about is Tylenol or acetaminophen. If you look under most drug books, it'll say the action is unknown, but Tylenol is thought to block the peripheral pain receptors and to simply increase the client's pain threshold. It has great analgesic and antipyretic properties, which means it treats the pain and brings temperature down. In fact, the antipyretic properties of Tylenol are just as good as those of the NSAIDs or non-steroidals. There's no antiplatelet aggregation, as you would see in, say, as you would see in aspirin. And there are a few anti-inflammatory properties that you would see in aspirin and the NSAIDs. However, there's a lot less side effects than the NSAIDs. You won't see the GI upset that aspirin causes, for instance. And remember how asthmatics should really avoid aspirin. Tylenol or acetaminophen is a great alternative for them. However, acetaminophen can cause hepato and nephrotoxicity, that's liver and kidney, with long-term use or with overdose. And Tylenol, unfortunately, is a substance used, I'm not going to say frequently, but it is used upon occasion for overdose. The maximum dose of Tylenol is 4 grams in 24 hours. Sometimes prescribers will write for 2 grams in 24 hours. So always make sure you look back and count how much the patient has received and kind of project for the next 24 hours so you know if you're reaching that limit or coming close to that limit or not. Okay, so now we'll begin a discussion regarding the NSAIDs, or non-steroidal anti-inflammatories. They are very popular. As you know, they have anti-inflammatory properties, generally from inhibiting prostaglandin synthesis. NSAIDs are useful in management of acute inflammation caused by tissue destruction, trauma, post-surgery, back and arthritic pain. Examples, ketorolac or Toradol is given. It can be given IV or PO. And probably the most common is ibuprofen, which has a lot of brand names, as you know. General dosing for that, the maximum 3,200 milligrams in 24 hours, generally divided up in 800 milligram doses. So 800 milligrams TID. The next slide will talk about side effects. Side effects of NSAIDs are very similar to side effects of aspirin, of course, and those are gastric upset is probably first and foremost. It can actually progress to GI or gastrointestinal bleeding, so make sure it's taken with food. And then, of course, a client should know to report any bloody emesis or stools. Can cause renal toxicity, decreased clotting. So when a person is on Coumadin, they should not be taking NSAIDs at the same time because those can work together. And NSAIDs can also cause sodium and water retention. So it can be a problem for those, obviously, who are experiencing heart failure, so watch it with older adults. Those with renal or hepatic elimination problems really want to be sure you're watching BUN and creatinine and watching for fluid volume overload. Okay, and then finally we're on to the opioid analgesics, which I know you learned about in pharmacology. This is just a real quick review of those, also known as narcotic medications. The action I've just written up on top, it binds to opioid receptors in the central nervous system and the spinal cord, and it blocks the transmission of the pain impulse. So just some reminders about opioid or narcotic analgesics. There's no ceiling or maximum dose, as there are with the other medications. And most of these opioid analgesics are similar, so they should only be on one. So when you get a client in the hospital, say who's on Vicodin, or a large amount of oxycodone, there's something called an equal analgesic chart that compares it to 10 milligrams of morphine. So providers use that to determine how much medication of whatever type they choose the client should be on. A general rule of thumb with the elderly are to start slow and go slow as far as increasing the dosing. So if they're on a medication, say 1 or 2 tabs or 2 to 4 milligrams, that you would start with the lowest and increase very slowly. Okay, some examples of common opioids. The number 1 would be morphine. It is simply the gold standard of all narcotics. It's inexpensive, and there's many types and forms of long and short acting. There's PO, IV, rectal. MS Contin is the PO form. It's very common. As you know, we give morphine intravenously on the floor quite a bit. Rectal, it is available per suppository, not as frequently used. Codeine is another common example. I guess what I'd like you to know about codeine is it may not work in about 5 to 10% of the population. In fact, 7% of Caucasians are missing an enzyme that is necessary to make codeine work. So if you're giving or administering codeine and you see that the patient's pain is not improving, you may ask them if they have an insensitivity to codeine or request that other medications would be investigated. Opioids are commonly presented as combinations with acetaminophen or ibuprofen. And many times they'll have long-acting and short-acting opioids together in one compound. Okay, so some common side effects of opioid analgesics. Probably one of the most common is constipation. And even though that may seem minor to healthcare providers, it can be very major to clients. So encourage them to increase their fiber intake, fluid intake, etc. Patients may experience nausea and vomiting, especially, of course, when they're taking the medications orally. So it's good to take it with some food if permissible. Watch for urinary retention. Watch for itchy rash or pruritus. A common side effect of opioids, and sometimes almost a desired effect, is sedation, but it can also cause confusion. So you want to monitor their level of consciousness. And finally, respiratory depression. I listed it last, but it really is the top priority, as you know. So you really need to monitor their respiratory rate and their O2 saturations. Now, you would expect that their respiratory rate would go down. And what I would suggest is when you count their respiration, say they get down to 12 or 10 per minute, go make sure they're arousable. Check their O2 saturations. Many times their rates will go down. That is expected. But if their saturations are okay, and if they're arousable, then they're probably tolerating that amount of medication just fine. And I apologize for this light writing here, but a couple other things I'd like you to consider is the reversal and synergism of medications. So these are terms I'm sure you learned in pharmacology, but synergism is when mixing drugs with other drugs to potentiate or enhance the analgesic effect. So Iggy, your book, describes this as a adjuvant analgesic activity. In other words, something that you would use in combination with. And I wrote a note here, what is a drug that reverses the effects of opioids? If we were in class, we could discuss that this drug is Narcan, most commonly. There are other reversal agents, but I think Narcan is the most common. What you would do as a nurse is mix the 0.4 milligrams, you dilute it in about 10 milliliters of normal saline, and push over about 2 minutes. Now, I think your handout may have a few extra words on it there, possibly, but you would push the whole 0.4 milligrams in over about 2 minutes and observe the client. Now, it takes about 2 minutes for Narcan to take its effect, and the effect of Narcan is about 45 minutes to an hour. So if the person is still depressed and you don't see a change in their symptoms or desirable change after a few minutes, you can go ahead and repeat it. And currently the suggested top limit is about 2 milligrams. So that'd be about 5 doses of the 0.5 milligrams. I just want to also point out that as a nurse, it's always good to know how you would have access to the Narcan. It used to be that when people are on large doses of analgesics, you would have the Narcan in the drawer near the room. But now with automated delivery systems, most patients have that as an override. So just be sure you would know how to get a hold of it before you would actually have to get a hold of it. And finally, I'd just like to put a plug in here for considering the medication administration across a lifespan. When working with the pediatric and geriatric populations, think about how are the meds absorbed, distributed, metabolized, and eliminated. Because really, if your client has any renal or liver considerations, you may have to, consider changing or requesting a change in medication dosages, increasing the dosages more slowly, or even changing the medications, because most pain medications are metabolized through one of those two systems. So it's just something to keep in mind as you care for either pediatric or geriatric clients. Okay, so now we're going to talk about pain medication delivery systems. The first one you are hopefully familiar with. We've talked about it in skills, and a lot of you have seen it in the acute care setting. That's a PCA, or patient-controlled analgesia. This is where the patient actually determines how much medication to take. Research has demonstrated that it provides for more steady coverage, smaller, more frequent dosing, and it enhances a client's sense of control, reducing anxiety. It's been demonstrated that patients who have patient-controlled analgesia actually consume less medication than patients who have just a PRN IV push type of medication. Okay, patient-controlled analgesia involves setting the pump in a certain way that reflects a provider's orders. The provider's orders very much read like a recipe. One of the things that may be ordered is a loading dose, and this is a certain amount of medication that is delivered on the onset of the PCA. So when you set up the patient-controlled analgesia pump, it'll actually ask you, is there a loading dose? And you can hit yes or no, and if you hit yes, you have to put in how many milligrams is ordered. You'll have the option of instituting a basal or continuous rate, and that would be a very small amount of medication that's being continuously delivered. We don't see that very often, although once in a while you'll have a provider that orders the basal or continuous rate at night. So that would mean the evening shift would have to change the settings on the PCA pump every night, and then of course in the morning have to change them back. The provider will also order prescribed doses and lockout intervals. For instance, when they push the button, how much will be delivered of the medication. Common dose, for instance, of Dilaudid would be 0.1 milligrams. And then the lockout interval would be how much time in between dosages would be preset. For instance, you can have 0.1 milligrams every 15 minutes. FYI, the 3 common medications used for PCA pumps are Dilaudid, morphine, and Demerol. Now, these settings, loading dose, basal or continuous rate, prescribed dose, and lockout, you could actually add to that 4-hour limit. Most pumps have that as well, so maybe the physician will say no more than 3 milligrams of Dilaudid every 4 hours. That's just a random example. But those will need to be checked by 2 nurses. Okay, here's a common PCA pump. This is, I think, the same kind of pump we have at our lab at NTC and the ones that are at our facilities here in Wausau. And as you can see, there is a key that keeps the medication secure. And also that key you need to unlock the machine in order to change the settings, again, which needs to be verified by 2 nurses. And as you're aware, the patient will need to press the button. They can press the button as many times as they want. The medication will only be delivered as often as a lockout is set. For instance, if the lockout is 15 minutes and the patient's pushing the button, say 8 or 9 times in that 15-minute period, they'll only get the medication after 15 minutes has expired. What I have noticed is there's a different sound or beeping when the patient pushes it and they actually get the medication delivered as when the medication isn't delivered. And you'll have clients who become very savvy to that, and they'll know exactly when medication's been delivered or not. So when setting up a PCA pump, not only do you have to consider the legal ramifications, such as checking the settings with 2 nurses and making sure it's locked, etc., but think about, is your patient a good candidate for a PCA analgesia? Very confused or weak patients are not good candidates. They're not able to push the button. Or if they're paralyzed, obviously they're not able to push the button. Now with children, this mode of medication delivery is found to be effective with children as young as 7 years of age. But really any younger than that would probably be inappropriate. But I wonder how many of our pediatric clients who are, say, 8 or 9 years of age have gotten to use a PCA modality. So make sure your client's appropriate and that you've educated them that they can push a button as much as they want and they will not get overdosed or receive too much pain medication. Okay, now I'd like to talk about medication delivery methods that are delivered in the spinal cavities. The first one is the epidural analgesia, which is delivered within the epidural space, and I believe I put a picture of that in your handout in the next slide. This can be either short or long-term pain control. The second that we'll talk about briefly is the intrathecal analgesia, and this is within the spinal canal. It's generally used for more long-term control, and there are some more CNS risks associated with intrathecal medication. So again, the epidural analgesia is administered via a catheter that is inserted within the epidural space. Okay, and the intrathecal analgesia is actually administered via a catheter that's inserted in the intrathecal space. And this space is really the actual space that's surrounding the spinal cord. It's also called the subarachnoid space. You may recognize that term. And just a word about intrathecal medication, it's becoming more and more popular that these are placed usually during surgery and attached to a pump. The pump can be internal or it can be external. And many times when it's internal, it's kind of placed in the abdominal region. And there's a diaphragm in it that when it's empty, it can be refilled. So it's used for chronic pain. Before a patient is placed on intrathecal medication, they usually go through a type of trial to make sure they can tolerate it. Common types of pain that this is used for would be cancer pain, real chronic back pain, say, maybe patients who have had failed back surgeries or chronic pancreatitis, spinal cord injuries, etc. Okay, and as I said before, many times these catheters are surgically placed. Now, some of you may be thinking about epidural catheters that are placed for anesthesia purpose. In the very short term, they might be placed, say, at the bedside, but if they're going to be cannulated in the epidural or intrathecal space, many times they're surgically placed. Again, there are pumps used to infuse the medication. It could be an external pump, which I have a picture of on the next slide. It could be patient-controlled pump. More recently, I know they use a lot of these on the ortho-neural floor, and there are orders similar to the PCA orders where the nurses have to go through step-by-step for the epidural pump settings, and they can actually increase or decrease the settings based upon the patient's needs. So pain assessment is so important here. With epidural and intrathecal analgesia, they may have an implanted port, as I talked about before. Usually it's placed in the abdomen near the subcutaneous tissue. So when it is completed, there's a port where it can be accessed subcutaneously and refilled. They could have an implanted pump, which is kind of pre-filled and preset to deliver a certain amount of medication at a steady rate. What they have found with this type of pain medication delivery system, there's better pain control, and clients actually require less medication and have better outcomes. Here's a simple picture of intrathecal analgesia, where the catheter would be placed surgically right along the spinal cord there in the subarachnoid space. Catheter tip is up here, and this is kind of a posterior view, but the pump would be facing forward to the abdomen with the with the port facing forward, so it can be refilled when needed. Okay, so side effects of these medications are very similar to the IV push medications: pruritus, nausea, vomiting, respiratory depression. Again, number one, gotta watch O2 saturations, arousability, urinary retention, lower motor weakness if an anesthetic is used or even partial anesthetic is used. So make sure you assess that before a client gets up on their own. And then the nurse's role, besides the pain assessment and adjusting the pump as needed per order, would be to monitor the site to prevent dislodgement and infection. So also, because it's in the back, make sure when they're repositioned that the tubing or catheter isn't kinked behind them. Okay, so as I said, there are preloaded pain pumps that are frequently used. We see a lot of these with the orthopedic surgeries. They're placed during surgery and filled with a local anesthetic agent. Bupivacaine and lidocaine are probably the most common anesthetic agents used. Common example is a Stryker pain pump. I think I have a picture or a YouTube video on Blackboard of a pain pump that's being discontinued at home. It's not unusual. And I do have a bullet below that says removal, that this would be removed by the patient or a family member in the home setting. Again, usually it's for orthopedic surgeries. They're pre-programmed, so there's not a lot of settings that have to be confirmed with the nurse. As far as teaching, the client, if they're going home the day after surgery, will have to know how to clean with soap and water, or however the provider has prescribed around the pump. The pump itself, the tube, looks a lot like a Jackson Pratt. Here I will just forward in a moment, and you'll be able to see. Some benefits of this are the patients feel more comfortable post-operatively. They can resume earlier ambulation. Generally, the hospital stay is shorter. And the patients perceive, and they are, more in charge of their pain management. Again, removal, whether it's outpatient at a clinic, or if it's at home with take-home instructions, there needs to be education that goes home with the patient and family members. Okay, here's just a picture of a common example of a preloaded pain pump. Here's a reservoir where the medication is put, and a real common combination of medication that's used today, or at least at Aspire, is a combination of Toradol, lidocaine, morphine, and maybe something else. So it's kind of a drug cocktail that is, and again, this is put in during surgery, and it is delivered at a certain rate. There's very little maintenance really for the nurse, except for to make sure the tubing is not kinked and that it stays clean, dry, and intact. Patient should be given discharge information as far as, again, whether they'll go to an outpatient clinic to have it removed, or perhaps they will give written instruction as to how to remove it on their own. One thing that I've read is, because this is delivering pain medication at kind of a consistent rate, that the patient should expect some clear drainage or leakage at the surgical site, because the medication will naturally kind of seep out eventually. So they shouldn't be real surprised to see that. Obviously, if they're having purulent drainage, or if it becomes more sanguineous in nature, they should report that. Okay, another pain delivery method is the IV conscious sedation. This is a common methodology that's used today. I think we've talked about TEEs, endoscopies, colonoscopies, cardioversion. All of those procedures require IV conscious sedation. So what is IV conscious sedation? It's administration of IV medication that produces optimally just a light sedation. It controls pain and actually produces amnesia. The unique thing about IV conscious sedation is that the patient is able to respond to commands and maintain their own airway. So for instance, during a colonoscopy, when the patient has to turn from one side to the other, they're able to follow that command. It's an increasingly popular option for many surgical and endoscopic procedures. It shortens recovery time. It reduces the risks associated, say, with general surgery or general anesthesia. And probably the most important thing for you to know is a patient really shouldn't lose their protective and deep tendon reflexes. For instance, under this type of IV conscious sedation, they would be able to respond to verbal stimuli. Example, in the cath lab, they might be somewhat sedated, but if asked to cough or hold their breath or turn their head or report angina, they could do so. Also, their protective reflexes, such as a gag reflex, should remain intact. Even though they're lethargic, they can be aroused. Now, there's a fine line between that and being too sedated. So in the next slide, I'll talk about how it's important to monitor their heart rhythm, O2 saturations, etc. Also, even though they should have their gag reflex throughout this, before feeding them or giving them something to drink, I would make sure that their gag reflex is intact. Okay, so to administer IV conscious sedation, you need to gather the right equipment, cardiac monitor if they're not already on that, O2 saturation machine, blood pressure cuff, respiratory emergency equipment, and by this I mean I always know where the airway is, artificial airway, and I'll have an ambu bag with oxygen present. Usually the patient is already on nasal O2, but make sure you have the ambu bag present, and you can always hook the oxygen up to the ambu bag if needed. Nursing assessment throughout the whole process is crucial. Their history, including concurrent illnesses, allergies, baseline vital signs. Make sure you have IV access. Usually there's an IV running at TKO that the medication can be administered through. TKO, again, means to keep open, unless the rate is more than TKO, but TKO for an adult is usually about 20 to 30 mils per hour. You make sure you know their baseline respiratory status. Informed consent must be signed for the procedure that's going to be done. Client should be in PO before IV conscious sedation and whatever procedure is going to happen. And as far as nursing ongoing assessments, make sure watch your respiratory status, which includes O2 saturation, definitely, and vital signs. And the goals, again, IV conscious sedation are to maintain the ability to follow commands, to breathe spontaneously. They should keep their gag reflex. However, you don't want the patient to remember what's going on. And I always kind of joke around because when you use this type of IV conscious sedation, even though they're talking to you throughout it and they can follow commands and respond somewhat, when they're all done, when they wake up, they'll usually say something like, well, when are we going to get started? Because it's very hypnotic in nature, especially if something like fentanyl or Versed is used, is the drug of choice. Also, as I said, we really want them to be able to breathe spontaneously, maintain the gag reflex, but plan for the worst case scenario. That's why I always have the ambu bag present. I don't leave the patient's side during the whole procedure, and make sure the ongoing assessments are done frequently and continuously. Okay, so the remainder of the presentation I'll probably let you go through on your own, but I just wanted to talk about a couple of things that are out there on the horizon, and these are only FYI things, so I'm not going to be covering them on the exam necessarily. But I wanted to pique your curiosity as far as to what the future might hold with pain management, what you may be working with in your career. And the first thing on the horizon is medication implanted during a surgical procedure that dissolves over time. Imagine you are going to go in to have, say, a hip replacement or a back surgery. And medication is implanted during that surgical procedure that would normally be very painful recovery. But because of this, you experience very little pain. There's no outpatient visit or drain or pump that has to be dealt with. Well, that's what's kind of being worked on with a medication that is an anesthetic agent called I always have trouble saying that, bupivacaine. And it's actually being embedded in a collagen material that is implanted during surgery. So it totally avoids the need for removal of a catheter by a healthcare professional or by the patient or a family member. And it increases the ability of the patient to resume ambulation or activities of daily living. So that's something that's out there in the future. And here are some examples of collaborative interventions for clients experiencing pain beyond the administration of medications. Okay, the first one and the only one I'm really going to talk at length about is the use of the TENS therapy, because we do see transcutaneous electrical nerve stimulation therapy used every once in a while, even in acute care. And it's also used in outpatient therapy, and I know a lot of, say, physical therapy companies may use a TENS machine. It is the use of electrical current produced by a device to stimulate the nerves for a therapeutic response or therapeutic purpose. Just an interesting story. I looked into this and found out that it was actually discovered or used in ancient Greece. And I'm talking 63 AD. It was reported that pain was relieved by standing on an electric fish or an electric eel at the seashore. So then in the 16th through the 18th century, various devices were used for headache and other pain, types of pain, to relieve them. And interestingly enough, Benjamin Franklin was a huge proponent of this method for pain relief and promoted its use. So I guess it goes back a long way. I don't suggest standing on any electric eels, but it is commonly used in outpatient and physical therapy rehabilitation, as I said. By the way, the use of TENS from different patients, just personally that I've talked to, some say when it's used it just has a tingling feeling, a burning feeling. Some enjoy it. They say it feels warm and relaxing. Others have said it's a painful experience. So there you go with different perceptions of pain or pain threshold. Okay, I've included in your handout a bunch of ideas for non-pharmacological pain management strategies that you may and should be using with your patients. Not that you would use all of these, but certainly pick out certain ones that might be helpful. Distraction is a hugely helpful technique, especially with the pediatric population and with the elderly. In with the distraction, I would include reminiscence therapy. Is very helpful. Just remember, all of these techniques, although they don't actually influence the cause of the pain, can alter the perception of pain. Okay. Here are some examples of complementary and alternative therapies that patients may use or they may be referred to. Again, I'm not going to test you on these, but there are certain areas in our community that deal with a variety of these techniques. In case you are not familiar with them, you can certainly look them up individually. I know for me, I wasn't sure what shiatsu was, but it's actually a finger pressure technique where it includes massage of the fingers that's supposed to stimulate referred pain relief. And as I was reviewing all of the herbal therapies out there, I got a little overwhelmed. I mean, there are entire textbooks dedicated to herbal therapies. I put down the ones that I felt were most common. I think the most important things for a nurse to know is we need to assess for our clients' use of these medications. Clients should know or be educated about their relationship or interaction with other medications or conventional medications. They need to know to report them to their healthcare providers because they can have interactions or even contraindications with some medications. The other thing to know is, for the most part, even though these have indications for use, they are not FDA approved, and just something to keep in mind. So in conclusion, as I said, clients should always discuss the use of herbal medications or supplements with physician or practitioners. And if they do have a planned procedure or surgery, many times it'll be stopped beforehand. However, if you have a patient who's coming in before a procedure or surgery who's on an unreported herbal medication, I would certainly make sure the provider knows about that before they go into that procedure. So I hope this recording was helpful. If you have any questions, please give me a call. And I hope you all have a wonderful week. Goodbye.